Welcome and thank you for joining 10 Conversations for 10 Years. I'm delighted to introduce the 10th and final conversation in this series that I hope you've enjoyed. I'm Amar, Chief Quality Officer at East London Foundation Trust, and I am absolutely thrilled to be joined for this final conversation in the series by Don Berwick, the man who literally needs no introduction to most of you. Don, you have led this field for 30 years, having first set up the Institute for Healthcare Improvement. You've shown us the power of improvement to improve outcomes. You're seen as the spiritual leader for the movement of healthcare improvement across the world. And I know you followed our journey at East London Foundation Trust closely over the last decade. Thank you so much for finding some time to join us today.
It's a real honor, Amar, and a delight to see you.
Wonderful. Well, I have a lot of questions for you, Don. I hope that's okay. And I know our listeners will be curious to hear your advice too. I wondered if we could start by just looking backwards. Part of the point of this series of conversations has been to help us learn from looking backwards and then think about the future. And, you had the foresight to bring approaches to management and improvement into healthcare over 30 years ago now. And I'm just wondering what your reflections are on what you've seen in the field of healthcare improvement over that period. How have things changed, and what have you seen about healthcare improvement over the last 3 decades?
Well, thanks for the kind comments. I guess I have to start by saying none of what I've been privileged to be involved in I've done alone. I mean, the actual beginning of this work came from a group of people who remain close friends and have worked together now for 3 or more decades. So I'm a member of a wonderful society of people that are trying to improve healthcare. Everything's changed. I mean, it's a totally different scene from when I first started in the field. I had become aware of what I guess I'll call scientific approaches to improvement, complex things. Up till that time, I'd been party to the idea that you just yell louder or exhort people or add incentives, and that's how you get improvement, or study hard and be a hero. But 35 years ago, I got acquainted with the work of W. Edwards Deming and Dr. Joseph Duran and many, many other scholars who said, no, that's not going to work. We need to use science in very complicated environments where we're interdependent and learn together. That's what improvement really is. That was a tough sell when we started. I don't think people understood it. I think certainly in healthcare, there was a sense that, well, we don't make widgets. How could we possibly learn from aviation or manufacturing or other disciplines? That's all behind us now. I think that the idea that there are scientific approaches to making things better and we can do it together is now much more widely accepted. Perhaps a better sense of systems and how we work together. Much more interest in getting the voices of patients and families and communities into the work we do. And I think, more or less a more honest look at the defects in our care. I always remember when I started in the field, I was meeting with a group of surgeons and they were starting a quality assurance committee. And I said, well, why don't we call it a quality improvement committee? And one of the surgeons said, oh, no, we can't do that. People would think we're doing something wrong now. But now that's all in the past. So I think we have a sense that we better be better. I think it's a sense that we're in this together. There's a sense of systems thinking. So that's we're well into our adolescence. The problems, though, are that we haven't yet executed the changes we need thoroughly and embedded them deeply in the organizations that make up healthcare. Most boards of trustees and executives still are fighting a day-to-day battle just to get through the day, are looking very much at increasing revenues, the only way to improve. And so I think we have ways to go to embed improvement in the soul of healthcare the way I understand it. So, we're en route. We're en route.
One of the changes I've seen, even in the last 15 years, Don, has been an evolution in learning about how to co-produce improvement. Um, Healthcare being perhaps a more human-centered industry than some of the industries that have taught us about the scientific approaches to improvement. I just wondered, that human side of change that, Deming first described in Profound Knowledge, whether there's some learning that healthcare has taken in that field, which other industries are starting to learn from. From what we've learned around how to really truly co-produce authentically and meaningfully.
Definitely, and that's been a big change. When I started in the field, the we didn't really talk much about co-production or power relationships, or how important the voices of patients and families and communities are. Certainly, in the theory of improvement, we always knew that. I mean, the definition of quality itself is to meet the need, and so we had to hear the need. But the idea of co-producing care, I don't actually remember that very much in my mind, anyway. Um, Paul Batalden, co-founder of the I, really shifted his attention completely to that idea almost 2 decades ago now, and began teaching us about reconsidering the role of how we fit together, um, and that's changed now. I think that very widely people are understanding that healthcare is not like a toaster which you make in a factory and then you hand it over to a customer. It's not. No. We're in a constant dance, a constant dyadic or multi-party relationship with the people we're trying to help, and we do this together. Health is not made and handed over to patients. Uh, it's something we work on together. I have to say that the East London Foundation Trust, of all the organizations I've worked with around the world, is to me one of the very best models I've ever encountered of really driving this idea of making health together with the people we serve to a full extent. And I take a lot of lessons from watching what ELFT has done. I remember, you may remember, one of my visits to ELFT a number of years ago. You invited me to sit in on quite a large meeting of kind of a managerial meeting, and it suddenly came to me that in the meeting there were people with lived experience, your patients and families, right in the room, and I couldn't tell I couldn't tell the difference. I couldn't tell when someone spoke. I didn't know if they were an ELFT executive, a manager, a clinician, or a person with a patient, a family member, someone in the ELF community. It was quite an eye-opening experience.
I think, we've certainly been on a journey learning about how to involve people meaningfully and then co-produce alongside our improvement journey. In fact, it probably predates our improvement work, starting to think about how people could be involved in helping us learn how to make things better, and then evolving from that into true co-production, and then actually people with lived experience leading the organization and leading service delivery, which is where we're heading to next. So I think there's still plenty for us to learn. I think our service user leaders would say the same, that we've come quite a long way, but there's a lot still for us to do to embed this fully as a model. But I guess one of the other things I was wanting to reflect back to you, Donald, in that very session you were talking about, you talked with the group about healthcare not being a repair shop, but thinking about our role as creating health instead, and how we need to go outside of our own organizations in order to do that. And that's probably been another shift in healthcare improvement, about really applying our skills with other organizations and agencies and partners that we wouldn't usually, with schools and churches and community groups and social care. I just wondered what you were seeing around the world about how healthcare improvement is being deployed in ways that are really about health and not just about care that we deliver in hospitals or healthcare settings.
To me, it's an and. I mean, we do need to do the repairs, as it were, and I think that everything we do in healthcare today that is repair, we should take very seriously and do it right, with attention to patient safety, making sure we're using the best science, with incorporating of the voice of the patient into it, with minimizing waste, and making sure we're doing it equitably. So by calling it a repair shop, I don't mean to demean the health care repair work. We better do it. That's one of the glories of technology. But if there's anything we know from epidemiologic science and understanding the well-being, that health care, that repair, can never make health. That's a very important assertion. Health care cannot create health, except maybe a little marginally when we do preventive work in our clinics. We do know what creates health thanks to very important research through decades, a lot of it in the UK. I often cite the work of Sir Michael Marmot, probably I'd call him the leading scholar of this question: what makes health and what makes gaps in health? And the agents, as you know, Amar, they lie in the community, in the way we treat young children, and birthing, and early childhood, in the education systems, in our workplaces, in our elder care uh, uh, supports, in community infrastructures, transportation, and food security, housing security, criminal justice. That's what generates health. And by the way, it's very powerful stuff. Uh, Michael has written that if we were to do away with all the heart disease in the world, we would only add 4 years of life to the human being. If we closed gaps in equity and justice and community infrastructures and early childhood, the results could dwarf that. So, what am I seeing? I think worldwide we're talking about it. Certainly, in the National Health Service in England, we absolutely saw that in the long the 5 year plan and the extended plans when Simon Stevens is running the system. Scotland has done great work on community well-being. I work a lot with Singapore, and Singapore is really trying to change their whole system toward a healthy Singapore aim, not just a better healthcare aim. Um, so, country to country, it's certainly being talked about. Problem here is, though, it's deep, which is the patterns of investment, the way we currently use our resources, are very much weighted toward the repair shop. We have gleaming, beautiful hospitals, or we work really hard on innovations in clinical care, and it's really hard to wrest those resources or recover resources for investment in community health. Even in the National Health Service, which certainly has spoken the language of community health for a long time, when austerity hit it, and the people were trying to get through the day, it was social services and community investments that suffered the most. We're not walking the talk yet. We're not. We know what to do, but we're not really doing it with the energy we're going to need in order to harvest real health for our communities. So there's a big change ahead. And my answer is, I hear all over the world countries talking about it, but we've not yet gone to the real kind of foundational change around what our countries are investing in.
What can the improvement community do to help shift us towards this? I mean, if I was thinking about, as an improver, how to really equip myself for the years to come and what the future of the field is going to look like, what would your advice be?
I think three things. One is, don't give up on making the care as good as it can be. We owe our communities safe care, effective care, scientifically grounded care. So continuing to improve care, we don't get kind of excused from that mission, even as we try to struggle with these upstream causes of illness. So that's important. A second is that we in the improvement community probably have more knowledge about waste and waste reduction, how to reduce uh, resources, uh, reduce activities that don't add any benefit, because we have to find money somewhere to put into the social sector and so on. So make sure that every pound we spend is spent on something that matters. Uh, because if we do that systemically, should free resources that could be devoted to the well-being. And the third is voice. It's like, we we need leadership from the healthcare community to say, let's get invested in well-being, and just don't underestimate what our community of improvers can accomplish by being very vocal and very involved. And then in our day-to-day work, reaching out, like ELFT has and others, we have to form new relationships with community-based actors, not just patients and families, but the many, many organizations in the social sector that can help contribute to well-being, as you mentioned, schools and elder care environments, not just care homes. Um, uh, Working across with important infrastructures like transportation and housing, they're in our they're in. We have to meld these worlds, and so we're talking together. And I think the improvement community can help with that. And also, by the way, I think the scientific approaches to improvement that ELFT has done so well in your core work, and that the improvement community is trying to teach and practice, they absolutely can work and help in the community based work once we're able to form the relationships and set the aims and get collaborative teams going. I I think the improvement community really has an obligation to be leaders in this movement toward achieving health, not just healthcare.
That's really an interesting observation, Don, and a bit of a call to action because often improvers will see their role as enablers, but not necessarily leaders. They will be led by where the leadership tells them to go in terms of problem solving, and they will enable and support, and facilitate and guide and coach. But what you're suggesting is actually we need to use the power of our own voices and our skills to be able to influence.
I think so. I could be wrong. Leaders do matter. I mean, it's going to be really hard for any workforce to help change the basic structures without leaders that want to do that. Uh, Equally, leaders can't do it on their own. They have to enlist the energies of the workforce. But I think, how to say this. I think this issue, how do we move from repair to health, is inevitably political. It had because we're talking about a redistribution of investments, and that never goes smoothly when there are incumbent organizations that have the money and they want to keep the money. And so there's a political side to this. When the you know let's say, imagine that in a dream, the clinical workforce of the UK, physicians, nurses, therapists, surgeons, unified their voice, and over a multi-year period kept repeating to the public that we want to do good work, we want to keep you safe, we want to make sure that we do the right thing, but we can never achieve health with healthcare. And so we, the healthcare workforce, strongly advocate new investments and shifted investments toward the generators of well-being. Um, that couldn't be ignored. It can be ignored when a politician says it, because what, they just want the votes. But when the professions say it, we stand a chance of really generating change. Now, that's bigger than your question about the improvement community. But of course, my hope and yours is that the entire clinical community become and act as an improvement community.
I know when we first introduced population health as one of our strategic objectives at East London Foundation Trust, alongside the three we already had, it took quite a lot of conversation actually with our clinicians to help them understand that we weren't asking them to do more. It felt like quite a lot to already do just to optimize people's care. And then to add on an additional objective around the health and outcomes for somebody, for many felt like we were asking them to do more. And actually, it took quite a time for people to realize that actually some of what they already do in their day-to-day work has the opportunity to influence people's behaviors and choices and lifestyles and interactions with other parts of the system to optimize health. And actually, part of what we're asking people to do is to perhaps do less in terms of care delivery in order to shift their attention to things that can prevent people coming to need our help.
Interesting. I mean, models of that, people that can testify to what it feels like to move their energies and not to do more, but to do things differently, that would really help. I mean, it seems to me clinical workforce is always operating in three roles. One is individuals in encounters with need, and in that setting, it becomes increasingly important to be able to inquire about the social context of the patients and families we see, and hopefully the organizations creating avenues of response. So when you hear that someone is at risk from family violence, or is hungry, or housing insecure, there's something to do with that information. That's individual clinical encounter. The second is at the organizational level. What is ELF's job? What's the mission of ELF with respect to health? How can you map that into your strategies? And then how can the clinicians become part of that? And the third is what I spoke of before, which is, I'll call it political actions, citizenship. Because, at the bottom line, the clinical workforce is a trusted workforce. There's no workers in American healthcare, American commerce. No workforce is more trusted than nurses. We know that. We have the data, which means that when nurses speak up to the topic we're talking about, that'll have force. That'll have force that others don't have a platform to exert. So individual, organization, and citizen.
And let's think a little bit about the future, Don. If you wouldn't mind just looking into your crystal ball and helping us think about what the next few years might hold. This whole series of conversations has been looking at the last 10 years. We've been grafting and trying to learn about how to apply these scientific approaches to improvement and co-production in our organization for the last 10 years. And we wanted to mark that milestone. But we're not satisfied that we are where we need to be. We want to continue to learn and adapt and grow. What do you think your advice would be to us in thinking about how to get from 10 years to 20? What does that look like? Because I'm not sure many health providers in England have sort of taken that path. What do you think are the things we need to be thinking about?
The list in the United States, where I am, is different. So I'm going to skip that for a minute. We can come back to it if you want. But in the UK, a couple things. One is, first, there is the lurking giant of artificial intelligence, which is, from what you read the newspapers, you listen to the experts, we may be at the threshold of something very big here as a new threat and promise enters the healthcare world. And so keep alert to that. That said, I would say we need to talk about results. That is, our aim should be about what is happening to patients, not our activities. And so I think there is a challenge in the next phase of the work we do together to really but to continue and expand our attention to, are people actually better off? So there's a kind of results orientation that I think is important to have. I'm not talking about pounding the table about management by objectives, but I'm saying really asking the question: are people's lives different? Which is it's the goal. It's what we're after. I think we better. ELFT has been a leader in this. So I'm really, this is Coles to Newcastle, but attending to the well-being of the workforce. As you taught me when we first met, Amar, if we don't attend to the health and well-being of the workforce, we've lost the game at the start. You can't produce great care and great outcomes with a demoralized or unsupported workforce. So really rethinking the workforce constantly and staying very much in touch with what matters to the people doing the work, so that we're building a better work environment. I think equity has received much more notice. Now is the next few years. It's closing the gaps. It's not just noticing or lamenting racial, socioeconomic, wealth gaps in well-being. It's closing them. And I would say let's put that at the front of the queue for the activities we engage in. All of this is unnecessary comment to you, Amar, and to ELFT. I mean, you are global leaders in everything I'm talking about, but those are some of the things that occur to me. I think there is one other issue, which is there's a question about funding and economics, which we have to solve. I do believe that the UK has everything it needs to have the best healthcare in the world. But right now it's gone a little off center for reasons I don't quite understand. So there is actually a piece of this to get back to the proper economics of healthcare, the proper support of healthcare. And without that, it's going to be very hard to carry out the improvement work we're after.
Mm. That's really sage advice, Don. I think one thing we introduced a few years ago, which I think will help us greatly, is a quality of life measure, which we now use standardized across all of our care pathways that really measure things like how satisfied someone is with where they're living, with their relationships, with the relationship with their clinician, those sorts of things, whether they're happy with their job, with their physical health, things that, sometimes feel outside of our direct control, but have an impact on well-being and quality of life. So for us, that's the start, I think, of heading in this direction of really truly paying attention to what matters to people in their day-to-day lives, and thinking about how we can influence that.
Yeah, bravo, bravo. I mean, the way that I think of it is what we do is always on the table. We can always change what we do. What we can't change is why we're doing it. And the why to me is the stable North Star. It's to do what you just talked about. It's to make lives better. And so this ability to continually question our activities, our systems, our approaches, our habits, our beliefs in the service of the thing we always want to stick with, which is the well-being of the people we're helping.
And two other things I'm reflecting on. One is the equity call that you've just made. I've been really, really impressed with the number of teams that have wanted to actively tackle equity gaps and are bringing their tools of co-production and improvement to help them with it, and are now seeing results. And I'm, there's definitely an element of continuous improvement at the point of care where people can do things differently, and not always feeling like they're dependent on the politics and the structures and the large systems to necessarily change. There are things we can do in clinical practice that will make a difference, I think, and we're seeing a lot of results through that type of work. I think the other call to action I'm taking away is about the money, and I think for improvers, we need to make sure we're paying attention to not just the quality of care, but equally drawing the link between quality and cost and value and waste, and seeing ways to bring the two together, because I still think they're far apart in large parts of the system. Thinking and approaches to cost and quality are still not universal.
Yeah, on that latter point, I am a little skeptical of the concept of value for reasons we could talk about in another meeting. I think it can be an escape from the problem of just saving resources. Value is an equation, but I'm talking about something much simpler, which is as we go to work in healthcare and we see things that are dumb, that don't, they're not right, or they waste resources, time, energy, spirit, money. Our job as improvers is to stop wasting that. Is to together, not. I'm not being exhortatory about it. I'm saying it's just it's a goal. Um, don't don't spend a pound that isn't helping. Every pound should help.
I think all clinicians will resonate with, if you work in any clinical environment, you can see waste. One last question, if I may, Don. You've seen the English health and care system up close over many, many years, helping us think about safety and the integrated care systems that have been in development over many years now. And now we have a national approach to improvement, the NHS impact framework, with a real consensus around wanting to adopt and embed improvement across the whole health and care system across England. And, I have a role in helping lead some of that work. So I thought I might ask you for some advice on that, Don. What would you say to a country like England, with the way in which the health and care system is designed, the assets it has a lot of assets, and it has a lot of experience and strengths across the country, if it was really trying to do this at the scale that is set out in this ambition?
I feel somewhat reluctant to give advice to a country and a system I admire so much and am outside of at the moment. But some of my reflections are this: first, there is now I think an evanescent but very important period of stress and demoralization and even doubting going on in the National Health Service. I don't know its sources: COVID, overshooting on austerity, political disruptions, Brexit. I think there probably a convergence of factors that are causing the National Health Service to doubt itself and people to doubt. I'm sad about that, and I think it will pass. So my first hope is that people uh, don't lose heart, don't lose confidence. You have one of the most brilliant ideas on the planet with respect to providing health care and eventually health to people, the National Health Service and its charter. I think that there's a sort of belief I have that if you stay with the improvement theory and practice, it's highly respectful of a workforce. It works. It can reduce burden and better meet need. The improvement methods are not the luxury. They're the proper and necessary set of tools for getting through the troubles you're in now and getting back on track. So this is a time to do exactly what you're talking about, which is reassert the value of scientifically based, collaborative improvement work as a mainstay for our work. It's one of the exit pathways from the current problem set. Um, Stay together. The One of the paradoxes in I think in human interaction is at times of scarcity, when there's a sense of scarcity, our human reaction is to ring fence, just keep what I have and close around it. That's exactly the wrong thing to do. It's the time when stress is high. That's when you share. That's when you begin to realize that we only have each other, and that if we cut ourselves off from each other, whether it's outpatient care and inpatient care, or medicine and surgery, or mental health and physical health, this is a time to widen the embrace, not to ring fence. And so I think there's something to think about. Now, in the National Health Service, I think that the integrated care system idea is exactly right and holds enormous potential. And so my feeling right now, and I guess I'd have to be there and talk with more people to be sure of this, is to double down on the integrated care system concept. A defined population served by a totally integrated or organizational framework with a single control total, a bottom line that is completely shared, and where the consciousness of the population being served and all of its needs is at the center. So my general advice is perfect the integrated care system now. You've got the idea, you've got the structure, lean into it, and don't be cynical about it. Be generous and optimistic and hopeful, happy about it. And I think it's a platform that really can be the next uh, historic presence of the National Health Service in the work of your nation.
Well, thank you so much, Don. It's been an absolute privilege to speak to you as always. You're a source of wisdom and guidance. My personal thanks to you for all the support and guidance you've given to me and to this organization over the last 10 years. We really wouldn't have got to where we are now without your personal support and counsel and that of the IHI. So big thank you to you, and thanks for this conversation today, which has taken us into really interesting territory. So thank you, Don.
My pleasure, Mark. If I can tell you a very quick story in closing. The first time I ever heard ELFT was when I landed at Heathrow Airport and was traveling into the city, into London, with my colleague Bob Lloyd, uh, one of your mentors. And I was headed somewhere else, but Bob was headed for ELFT. And this was 10 or 11 years ago. And he said to me, "Have you met these people?" I said, "No, tell me about them." He said, "They're really special." And he was really right. So I recall that.
That is very kind. A lovely story I've not heard before. Thank you, Don. And we have reached the end of the final one of these conversations. So To those of you that have listened along the journey, thank you so much for joining us. To all the guests that Pedro and I have had over the 10 conversations, thank you so much for sharing your wisdom with us all. It's been a real privilege to host these 10 conversations that have marked the milestone of 10 years of quality improvement at East London Foundation Trust. And obviously, all the conversations are there for you to listen back to at your leisure. So thank you again, and see you soon.